what a pleasure it is to be here, and thank you very much for the opportunity. Of course, there's no way that we could be doing what we're doing without the excellent work that all the previous speakers have done, especially Dr. Theodore. I owe you a big thank you for the robot, so thank you very, very much. Just a word to the fellows. I remember what it was like to be a fellow, and I can tell you you're going to have a great year, you'll learn a ton, and that life does get a lot better very soon. So hang in there, keep up the good work, have a great time learning, and know that there are good times very closely overhead. You're about to crest. So have a great year and enjoy your teachers and what you're learning. Today, I have the opportunity, first of all, to meet this wonderful gentleman across from me, Dr. Elias. Very grateful to have an opportunity to be with him and to talk a little bit about something that I'm very passionate about, and that is the use of robotics in spinal surgery. There's people much more articulate than I am, and certainly with much more gravity behind them, that have talked about robotics, but I'll give you my 2 cents. The robot makes us safer, it makes us faster, it makes us more precise, and allows us to do minimally invasive techniques that previously would confer a disadvantage to the patient. Now we can do confidently, knowing that our hardware is going to be exactly where we want it. It also allows us to think about aspects of the surgery before we even get into the operating room, and this is my transition into what we're looking at on the big screen here. This is a CAT scan of this particular cadaveric specimen here that was generous enough to donate their body to the research and learning. This CAT scan was then programmed into the robot software, and then we can use this opportunity before we even get into the operating room to plan where our screws are going to go. And so I'll direct you to the screen itself. We have the ability to place a screw in here with just simple drag and drop type iPad kind of movement. We can then fine tune it to exactly where we want it to go with these smaller controls and check that, is it fully contained within the pedicle? Are we where we want to be? If you can direct yourself to the lower left-hand side of the big screen, you'll see that we are touching on the bottom part of the mid portion of the pedicle there. It'd be nice to get that a little bit more centered, so why don't we just make an adjustment there? And there we are, smack in the center. If we wanted to, we could try making the screw size a little bit bigger and really maximize that minimal pedicle. Can we get the most engagement into the cortical bone to really get good pull-out strength? And in this case, yes, we can. So that is one of the big advantages. Another thing is we can look on the upper right side of the screen and see that we have the angles of attack for each one of the screws, as well as the distance between the screws noted there. So we can make an effort to have our screws line up. They're going to line up and not be too far astray. So we can plan our rod construct there as well. And we can also use this technology to plan for corrections. If we have a spondylolisthesis, we can place one screw deeper, one screw higher, and use that power with the rod. And of course, your excellent decortication there to allow that to move up. So that's how we basically program the robot. We can double check in this screen here on all 3 views. Do we like the way things are lined up? And we do. And then we go and register to the patient. So in the operating room itself, at this point, you would bring in your fluoro machine and take an AP and a lateral image, just 2 shots. That is then referenced to the robotic technology via these fiduciary markers. And then the robot knows in space where the pedicle is. After that's done, and that's a relatively fast process. I mean, it's an APN lateral, so if you have your one-shot Bob technician, he can just bang it out. You might have to talk some of the less experienced ones through it, but it's just an APN lateral. I don't even wear lead anymore in the OR. I just stand in the back. They take the 2 pictures, and then I come back to the field. Now that we've registered and we have linked the images in the computer to the specimen in front of us, we can now execute the movement. I'm going to demonstrate, or Dr. Elias will demonstrate for us, on the right-hand side of the specimen, a percutaneous technique, a purely percutaneous technique. And then on the left-hand side, I'm actually going to demonstrate my preferred technique, how I do it. So we'll start at L2 on the right. I'm going to touch that tablet. It will light up. Then I will press this sort of accelerator pedal on the floor here, and the robot arm will move into the position where the screw is supposed to go and direct us into the right location. Once it is settled in, it'll go green and make a little chime, doo-doo-ding, and we now have the ability to excuse the noise, we now have the ability to make a stab incision. Now, Dr. Elias, I will remind you this is cadaveric tissue, so you're going to have to make a slightly larger incision than you would in tissue that's more pliable and alive. And we want to be up and down in the patient's orientation there. So go ahead and stab in. Again, you'll feel a little bit more resistance because it's cadaveric. And in fact, just so that we make our life a little bit easier here, we're going to enlarge this just so that we don't have to fight the sort of semi-frozen tissue there, okay? But in real life, you would just come in, make your stab, and come out. Now, we can know from our planning that there's a little bit of a bump where we're planning to have our actual drill go in. So we're going to touch it very briefly with this burr to just freshen it up. And that's the equivalent of what I believe Dr. Lenke calls making the little cherry there. So you're going to go down until you've made contact. You shouldn't have to force it. It should just kind of rest down there. And if you look on the screen, you can see your instrument is touching indeed where you're going to go. So at this point, you'll just turn on the burr at full speed, hold it, and just lightly touch it. There we go. And you can come on out. And then come on out. You're good. We're going to hide this from the camera so it doesn't interfere with our next instrument, which in this case is a end-biting mill. It's not actually a drill itself, it's a flat thing. And what you're going to do is place this again down through the cannula, not forcing it in any direction, watching where your tool is on the screen. And again, without applying any major pressure there, you want the robotic arm to guide you in place. You're going to go ahead and turn it on full speed and let it go down now you can see from your navigation, you're headed down the pedicle. Go ahead. There you go, full speed. And it will stop you at the predetermined length. You can then come out. Now, many surgeons like to tap. I happen to be someone who does generally like to tap the hole, especially in either really osteoporotic bone, where I'm afraid that I might break the pedicle, or in really robust bone. So we can place the tap down, and this instrument also shows up on the screen there, and we can watch as Dr. Elias advances the tap down the pedicle. The little tip is marked by the little plus mark there. And that's probably enough to make sure that we're safely down there, so we can reverse the ratchet and take that out. All right, excellent. And then lastly, we can place the screw. So in this case, we have the screw going in, making contact, and we can physically see the screw being advanced into the patient. Now it should just fall into the hole that you already made, so you don't have to force it. Doing a great job. I think somebody give this man a job. Excellent, very good. So now we can remove our screwdriver and go on to the next screw. So in this case, we're going to go to my side. And what I've done on this side is, prior to the lab, I dissected off the paraspinal muscles and moved them laterally, exposing the lamina. And this is my preferred technique to do this. And generally what we do is we have my assistant hold the skin back, and then we do essentially a perk screw through the muscular fascia, through the muscle itself. And then later, once we're doing the decompression, we can take a Meyerding and look in from the opposite side and connect the heads up that way. And in that way, I can see the nerves as I'm doing my inner body work and my decompression. And yet I still have the advantages of not having a retractor pressing on that muscle the whole time there. So looks like our skin is a little less compliant than I want, so I'm just going to make this a little bit bigger just to get some of that tissue out of the way. And now Dr. Elias is going to hold that steady. And again, just the flesh itself, you don't need the fascia. Perfect. And let's send the robot again to make sure that we're in the right trajectory. So it's going to give me a green and tell me that I'm okay. I'm going to go ahead and make the stab wound. And then, just for illustration purposes, I'll use the burr. I don't typically use this a lot in my real practice, but I think it is helpful to see that on the screen and to know that certainly if you have any instances of potential skive, and that is to say, if you know your drill is going to be going on an area that's at an angle, you can burr that and make it flat so that your side biting mill here, or the drill, for lack of a better term, will have a safe place to land. So we can see here on the screen, on the computer, that our drill is the trajectory that we want. Go ahead and start that full speed and advance that down the pedicle. All right, we can remove that instrument. Again, tapping is personal preference. Some people like it, some people don't. I think it's helpful, especially when you're dealing with the extremes of bone, really good bone or really bad bone. I've made enough of a path with my tap there that I can place the screw here and have it engage. Very little pressure at all. Not having to force anything. I'm using just fingers to advance this. And we can get the screw to go down right where we wanted it to go. Okay. I get my check mark that says I'm doing okay. Like most spine surgeons, I need a lot of extra validation, and so there it is. Now, when we do these screws, because we're working on a reference frame, we want to start away from it and then work ourselves down. And I prefer an S-shaped pattern, so left, right, left, and working ourselves down. So in this case, we're going to go to the L3 screw on this side. And we'll ask, okay, well, that is a first for me. Let's see what we can, we'll try.
Humans to the rescue.
Motion, locking, end effector check incomplete. Well, one nice thing about new technologies is oftentimes you have an opportunity to try new things. So we're going to troubleshoot that. Sometimes we can do a quick reset of the software, and that'll correct the problem. So where am I? Right here?
Yep.
This shouldn't take too long, but while that's going on, let's talk a little bit about some of the data on robotics. We have found at our institution that for single-level constructs, that our time is actually faster with the robot than without the robot, and our screw accuracy, of course, is improved. You know, a lot of things that make sense, you still have to prove, and in our case, we were able to show that. And there's other institutions that have shown an accuracy improvement to the point that you're really looking at near superhuman ability to place these screws in exactly the right place. So now we're at our L3 trajectory, and you can see on the screen that our drill is where we want it to go. And we're going to go ahead and advance that down to the pedicle. And in this case, I'm going to go ahead and skip the tap and go straight to the screw. And this is the way most of my screws are going to be placed, is with the drill and then with the screw, maybe a little brief tapping again in those extremes of bone. All right, Dr. Elias, you're going to get to do the next one. So let's head over to L3. What are we? Okay. So it does move fairly quickly, and in fact, while you're finishing up on the one screw, your assistant can be moving it over to that screw, and you can be a step ahead. Two of my partners will routinely bounce back and forth between the sides, so one's finishing up the screw while the other one's starting on the next one, and it can be pretty fluid. All right, Dr. Elias, you feel ready? Mm-hmm. Make it so. Give a little Star Trek reference there. Now go ahead and enlarge that incision in the north-south, just again, because where tissue is still a little rigid here. Good. Excellent. Yeah, that's a great place to put that. Let's go ahead and make that again. Just touch the very tip of that to the bone to give yourself a nice landing zone, so that you're not dealing with an angle. You're dealing with a nice flat area for your drill to hit. So he's going to just touch it, and doesn't have to go deep at all. Just a little touch to flatten that area out. Mm-hmm. And what's nice about this is you can get that tactile feedback and also the visual feedback from the navigation. And as a teaching tool, what's nice about this is the robot basically keeps you in the right trajectory. It's pretty hard to overpower it. So when you're placing screws this way, you can be fairly confident that they're going to go where you want them to go. So full speed, and it'll bottom out there for you. All right. Let's go ahead and use our tap. Thank you. When I first started using robotics, I started with a Generation 1 unit, and then later I had the opportunity to move up to this Generation 2 unit. A couple things I had to learn, and it did change my process a little bit. I do place my hardware first now and then do my bony work and my decompressions. But the biggest liberation for me was that all this hardware stuff takes place at a different time and a different location than the operating room. I think about where I'm going to place the screws, how I'm going to align things before I'm actually there. So when I'm in the operating room, I can use that mental energy and that physical energy to get the hardware in and then do what I came there to do. I came to make the patient better. The hardware is a tool to help me do that. So I didn't focus on the hardware, I focus on the patient. I get my screws where I want to go, I reduce the spondylolisthesis, I decompress the nerves. I spend more time now. I have more mental energy, I feel better, my cases take less time because I'm not having to check all these fluoro shots. And okay, so you got your check mark there, mm-hmm. And it looks like we plowed in a little bit, but okay. And I find that to be very, very liberating, and truthfully, probably better for my patients. I'm not in that, is the screw in the right place, and worried about that. We're going to move on to the L4 following that serpentine pattern. Now, I have heard people say, well, what happens if somebody really torques on this? And you'll see that there's a force meter here that'll show if things are getting out of place and give you an audible and visual warning. And you know to resend it and put it back where it belongs. What happens if your instruments skive a little bit? It can actually identify that for you and tell you, hey, you're headed in the wrong place. So after Dr. Elias makes a generous incision for me, I'm actually going to use the burr and show you how one can abuse this system and what the system does to warn you about that. Okay, very good. So I'm placing the burr in, all right? And now I'm really gonna use my weight on it. And you'll notice it says excessive deflection force. That's a kind way of saying, Andy, don't be such a stupid dude. Be gentle, go gentle. All right, now I'm back on track. Let's just say that something big happens, the table gets moved or something like that. I can then resend the robot and get my green view again. It'll re-register, it'll follow me, okay? So Make our little hole there. My fantastic fellow. An appeal to the teachers at SSF, he has not had a good dumpling meal, sushi meal, or Lebanese meal since he's been here. So please feel free to take him out and show him all that Seattle has to offer. All right. There we go. And this process can be quite fast once you've done it a fair bit of times. We did a lab here a few weeks ago where we actually showed that you can program to do some unusual trajectories as well. It is possible to get fancy with this, but for now, I think given this is its main use, 90+% of the time, this is what you're going to be using it for. It makes sense to show you this. It looks like we're binding up on the skin there. Let me go ahead and make that a little bit bigger for you. Go ahead and raise up a little bit. Okay, let's kind of free that tissue up a little bit. There you go. Is it still catching on there? Okay, great. Well, if there's questions from the audience, if there's a way to let me know, I will gladly answer them. I really appreciate the opportunity to show you this technology, and I welcome anybody to email me or watch some of my other videos, and I'm happy to talk about this. We're also very glad to have people come down and visit us. Obviously, the COVID-19 has limited that a little bit, but I'm confident that we will come up with a solution for that at some point soon, and I would welcome you to spend some time with me. Thank you very, very much. Are there questions I can answer?
So, Andrew, that was a great talk, and Elias, just watching you guys in the lab, it's to me, one of the cool things about using a robot is it's actually a great teaching tool because you can really see the anatomy in 3D. The other thing I think, and I don't know if you want to comment on this, Andrew, is that I think the more the staff know what the hell you're doing, I think it makes I know there's a, like with all new technology, it's a pain in the ass to get this stuff in the hospital. Once you get the hospital to sign off on it, then you get all the staff trained. But to me, visually, to have your nurses and your fellows see everything, don't you think that there's a value in having the team kind of know what it is actually that you're doing?
Absolutely. And that was one of those unintended consequences when I adopted robotics. The ability for the people in the OR to see exactly what instrument you're using. They can load up the screw and it's right here. There's no guesswork involved. They know exactly what you're going to do. The fact that they can watch in real time how the instrument is going into the patient and coming out of the patient, again, teaching tool, but also very helpful for the staff around you. Okay, he's tapping that. I can see why, and that one's got a big bump. We're going to use a burr. It's been very, very helpful for us, and it also lets them feel much more involved. It's very easy when all you have is a couple poke wounds in the patient to feel that you're not part of the part of the solution, but you are. And everyone in the OR plays a role. And this, I think you're right. It gives them a connection to this real person here that we're really trying to help. And it's been helpful for us. That's one of those intangibles that we have seen and enjoyed in our program.
Elias, how was it for you, using the robot for the first time? What do you think?
Yeah, so this was the first robot experience for me. It was very straightforward. It's like I'm just following whatever was already registered in the navigation system.
Yeah, it's interesting, for me, and I think the other question, actually somebody commented on this, is that, there is a cost to all this, right?
Yes.
You didn't discuss that, and what's your advice on, fellows going out to practice, in a year, how are you able to get the hospital to purchase something that's this expensive when they keep saying, oh, we're losing money,
Right.
we need to cut costs, and then you have to go through 20 different administrators to try to get something approved.
There is an emotional
Nice.
component to adopting new technology. This is cool. I really like it. I want it. And there's an emotional reaction from most hospital administrators. I don't want to spend more money on a system that's going to be outdated in a year. How many of those units are sitting in the back hallway gathering dust? What they're going to need and what you're going to need to have a successful robotic program is you're going to have a passion for this technology. You're going to have to want to build this program. The data behind this is actually very, very supportive. You can avoid takebacks. There's a very nice study showing that in single-level L4-5 spondylolisthesis cases, there is a measurable amount of cases that do not have to be revised when this technology is used. And we know revisions are very expensive. So you could make a cost argument saying, well, if I'm doing 100 T-lifts in the next 6 months, there will be less takebacks, and that each takeback costs X amount of dollars. That's how much we're going to save doing this. And I have found that the robotic companies are very eager to get this technology in and are very willing to work with the institutions on deals that make sense for that institution. So once you've identified that you're that person, I am the doctor that wants to be passionate and advance this technology, and you become the champion, the rest of the pieces will fall into place. Now, it might take a little bit of work. You're going to have to really leverage some of those relationships in the administrative suite, but you can make this happen, and it can be good for everybody. My place and the CFO at my hospital is more than willing to talk to folks about how we made it economically viable. We actually do better with the robot than we would without. And those are success stories that should be shared. But it really comes down to the surgeon willing to lead the team, to teach the team, to spend time with them. And that doesn't mean just teaching in the OR, that also means teaching in the O suite.
That's great, Andrew. So, Elias, if you could just grab the robot and take it downstairs, that'd be great.
That would be great. That would be great.
So thanks again, you guys. Really appreciate you coming up, Andrew.
What a privilege to be here. And best of luck to all the fellows. And thank you, faculty, for letting me have some time. Thank you very much.
Great, thanks. Good job, Elias.
Thank you.